This meeting is being recorded.
So good afternoon, ladies and gentlemen. Welcome again to the series of Ebola Preparedness series. This is the second week. I know we have overwhelmed you with information. However, it's good to be prepared. We've noticed that if healthcare workers, as Dr. Maritim had pointed out, if we are more prepared and we are trained well, we would be in a better position to actually the trends are actually going down with training in terms of death. So this week we're going to talk about establishment of Ebola treatment units. Let's be prepared. And as usual, if you want to get the other platforms, you're going to get them at KNH Research YouTube channel. We normally upload the content there. And follow us as well on KNH Research for more up-to-date information. Today, our speaker is Dr. Denver Mariga. He's a medical epidemiologist in the Ministry of Health. Daktari, how are you?
I'm fine, thank you, Dr. Amina.
Yeah, karibu Daktari. You can take us away and enlighten us on the establishment of Ebola treatment units.
Thank you so much for this wonderful moment to be able to share with my colleagues on what all this is all about and focusing on the establishment of Ebola treatment centers. I hope you can all see my screen.
Yes, it's visible.
It will be a short presentation with a few explanations here and there. I'm hoping that within this the audience, we have individuals from counties, mostly the county HMTs and clinicians, because much of the welfare here is on clinicians and how they can be able to prevent themselves from getting the disease. I'm really sorry, I'm in a meeting area, but I'm hoping it will get quiet as soon as individuals leave. What do we mean by Ebola treatment centers? Basically, this is an area where individuals can be who are suspected or who have been screened and have met the test definition of Ebola are treated. I will be going through a few things on how this is done and what are the recommendations per the WHO, that is meaning the global body that is mandated in ensuring that individuals are safe and countries are safe, and also minimization of the spread of disease to the other countries. Basically, we are looking at here three individual levels: the design and the optimized supportive care of Ebola and the therapeutics that are there. Unfortunately, our neighbor Uganda has recorded Sudan Ebola virus, which is the main area of interest here for the country, and which unfortunately has not been known to have any vaccine ready yet for this. Fortunately for Zaire Ebola virus, there's treatment that has been there and also some vaccine that has come into the pipeline. So basically, this is one of the documents that highlights the drawings of what the building is all about. Fortunately, or unfortunately, I would say in this case, we are not mandated to copy the design as it is, but we can be able to tweak it to our area of interest and also depending on where the cases are evolving within our environment. Just the plan and the key elements that we are going to go through here. What is the Ebola Treatment Center? Some of the few principles, and we'll also some risk areas, identify risk areas, the access and space allocation, flexibility and adaptability within our environment, where it should be, and the materials and clinical aspects. And lastly, the psychological aspects and community acceptance. This one I will leave it to somebody else to take us through on that. When you're looking at the key objectives of this is to prevent the transmission of the disease and provide the best patient care. In this case, the environment is supposed to be comfortable and safe for the staff, both for patients and also families. And the area should allow for safe delivery of highest possible quality of care, and also taking into cognizance that patients need to be private and it should be accessible. And also should be around patients. We should not be able to take an ETU far away from patients, far away from their communities, as this also leads to loneliness, and also some of them are able to break out of the area, mostly the ETUs, and it becomes a problem to the community. Remember, this is a highly infectious disease, and contact tracing is very paramount. And in case you lose patients, that means the disease is ready and will definitely spread within the community. Where do we put an Ebola treatment center? As I mentioned, it has to be as close as possible to the epicenter of an epidemic. Chances are either within a new health facility that is existing. Unfortunately, initially, I think in West Africa, they had put them away from existing health facilities. And their reason was that this was because it hindered patients from accessing other healthcare services. And also the construction requirements. So you need a sufficient space so that you can be able to scale it up in case there is need on that. And also the soil condition. In this case, if it's in Kenya, God forbid, not near cotton water soil, which holds a lot of water and can lead to flooding within the area. What is the size that this is supposed to be? Basically, it's dependent on the disease pandemic and also on how the disease is evolving, whether you're having more cases or less, and also the size of the population. If you're going to set it up in Nairobi, you have to look at a bigger field where you can be able to scale it up or downsize it to a need be. And also the management, here you're looking at the healthcare workers who could be able to run the facility. And submentioned scalability of the facility is very important. Do not go for an area that is cannot be able to be expanded. That means you need more resources, or you have to build another one somewhere else. And that will mean that patients will have to find other means of getting to that place. What about the principles that we need for the geography? You have to make sure that the key objectives are put in place. So that is who is going to deliver the care, the nutrition, and the cleanliness of the area. Here you're looking at water availability, and the design has to be as simple as possible. What do I mean by this? In case you have your clinicians, God forbid, have been infected and you need to replace them easily, you should be able to get a team in with minimal training and high training in IPC to be able to run the place. And also they should be able to move around easily. As we'll see, the movement within an ETC is always a one-way. We do not retrace our steps as is common between our odd routes and all that. And also rationalize the space and the distance, meaning minimize the complexity for the management on a daily-to-day basis. Remember, this is a place that also has, the management is a little lean. You do not have so many people who are willing to enter into such spaces. And also services that are interconnected, let them be close together. What do we mean by this? Things like the lab and the pharmacy should be able to be within reach. And then the transparency of the place so that they are able to be accessible either by visitors or any other individual who is paying close contact to that. Also, patient quarters should be available. This is not an area where we are going to lump two people on one bed, because we do not know also the genealogy or the genetic profile of the virus at that particular time, if you've not done molecular, and also the kind of strain that the individual is infected with. So this is an area where each individual is maintained to have their own bed and also maintain their distance. For the risk areas in an Ebola zone, we have two basic risk areas. That is, you have a high risk zone, place where you have the staff and the patients. And we also have a low risk zone. Basically, this is where we have the staff, our supplies, and any other like PPEs that we can be able to put in before we enter into a high risk zone. And then the outer area is whereby we have the outdoors, where the family can come and visit your individuals, visitors, and the community to see what is going on. Unfortunately, during the 2014-2015 Ebola outbreak, initially the community was not given access to any information, and this one brought about people fighting the healthcare workers and even those individuals who are going to pick patients from the community. So it's always better that the community be involved in anything that you're going to do in such a case, so that there's buy-in and also they're able to pass over the information to the community, and you're also able to identify your cases very easily. The high risk zone is basically, as I mentioned, contained within the low risk zone. and the high-risk zone is completely surrounded by a double fence. As we go forward, you realize that the double fence is meant to have two borders. That means it will protect you between the low risk, that is, and then the inner one on the high risk. And as you look at the community on the outdoors, the community is able to stand outside the outer solid wall and be able to communicate with the individuals at that particular time. In the Ebola treatment center, in the high risk area, it's supposed to be fully enclosed, and this is an area that for entry, PPE is supposed to be paramount. That is full PPE, not the basic PPE. And the distance has to be maintained at all times. And also during the screening, when the clients come in, triaging area at the screening before they meet the case definition and ascertaining if they do meet, the distance has to be maintained. Fortunately, that there's one thing that nature has given us is IPC, which you can be able to maintain at all levels. COVID has shown us that you can be able to keep distance. You can be able to put on basic mask and all that. So PPE becomes the paramount IPC measure that we will have to be going through always during this case management decisions. On access and space allocation, as I mentioned before, we do not retrace our steps when managing for Ebola. As you can see in the high risk zone, in the screening area, this is where the patient enter. And as they enter, their exit is also different on that. And if they are found to be contagious, or they've been discharged, their exit is also on a different route as compared to the one they took in when they were coming. As you can see from the low risk zone, this is where the staff basically enter. And the low risk zone, the staff enter through that, then they don, and then after donning, that's when they enter the high risk zone. What is done within the low risk zone? Much of what is done here is handing over of patients, reviewing patients. As much writing does not occur in the high risk zone, so that you can be able to minimize the contamination of gadgets, either pens and all that. I know Google had come up with something of the sort, but also they abandoned it halfway with going in with the tablets. As the staff enter and leave the low risk area, they also do that through a dedicated area and a controlled entrance. And they are also screened before entering the Ebola treatment center. Remember, these are individuals who have contact with the cases, so screening is also done on them. I think they used to do it every other day on their clients, and also the body system. One of the things that has to be known when you're entering the Ebola treatment centers is that it's not an individual affair. It has to be done with a team. And the team, that means you're always supposed to be accompanied by someone else. There is never a hurry in you going into an ETU. Always take your time, don properly before going in, and make sure that you have a body for you before you are able to get in. When you are doffing, that's when you get from a high risk now to a low risk area. And that is one of the areas that contamination occurs to the healthcare workers who have been inside the high risk zone. So it's always a process for you to doff, never be in a hurry to doff. You can be in a hurry to don, but still do the right thing, but never be in a hurry to doff, whether there's a catastrophe outside or your colleague has gotten an emergency. Always doff appropriately, and also with the inspection of the IPC manager at that particular level. The space allocation is not done haphazardly, as everything is supposed to be considerate and also looking at the resources that you have at that particular time. Look at the services that you're going to put in that space and how proximal are they, not putting a high risk area and then the low risk area is about 1 kilometer away. So all this is done with coordination, and also the team, clinicians, the HMT team are supposed to be in cognizance of this when it's happening. And keep in mind the routes and occupied spaces to avoid unnecessary path crossings. This one is very paramount for the surgical team. Remember, you never cross hands when you're in a field of operation. So this is the same too when you're doing IPC management. Congestion and slowdown in daily management also should be taken care of. You should not be able to have so many people in one area, in an area. Always have numbered individuals on a shift, and nobody should be dropping in just because they are able to come to the ETU, because they pose a higher risk to themselves and the community. On the outdoor part, This is where the family and the visitors and the community are able to visit and be able to look for the visitors when they are visiting. There are individuals who have been admitted in the ETU. So this has to be a secluded area or somewhere behind mostly, where it also has minimal traffic, and the distance is also maintained. That is from both the two fences, where you maintain the distance, and then you can be able to have the client have a seat if they are stable enough, and then be able to converse with their spouses, family members, and relatives. Remember, this is a lonely place, and most of the people who are taken there, because there's so minimal also contact with the psychological counseling. So it's an area that always adhere that it has to be there, where clients and their family can be able to talk and converse. And one of the things you must maintain is that do not look at time that it's visiting now or anything. As long as the patient is stable and the family member is around, you can be able to go to that zone and be able to converse. How do we allocate the space? In the low risk area, we have the changing room, we have offices, pharmacy, the kitchen, the store, basically any other thing that has no contact with the client is always in the low risk area. And in this area also, we have to be able to know the individuals who come in and come out, so that in case of any infectious spread or anything contact with a clinician or a patient, we're able to do contact tracing easily as clinicians, so that you can be able to prevent the disease spread within the community at large when they go out. Remember, even with Ebola, unfortunately, the healthcare workers could mingle with the public, and then who were infected, and some had good immunity and were not able to show the symptoms, but when they go to the community, they were able to transmit the diseases to those ones who are suppressed. In the high risk area, basically, this is where we have the suspect, the confirmed, and those ones who are recovering, basically the convalescent. Always remember to separate a few areas here. That is the suspect area and the confirmed area. And also the clients, as they come in, counsel them on about the 2-meter distance when they are within the rooms, and also everybody maintaining their own hygiene and also equipment that they're using. That is plates, bed sheets, and not sharing at large. The space allocation, the border area, as you can see, we have those areas that are within on the fence. That is the screening area for the suspect and the confirmed, even the confirmed when they are brought in by ambulance from the community. Then the donning and doffing area, the waste area, the mortuary, and also the lab. These are areas that are within the border areas, so you should be able to make sure that they are well staffed, and individuals who are manning them are also in tandem and have a daily log from individuals who are coming in. Currently now we've introduced a new area, that is the observation area. The observation area is basically to be able to observe individuals who are confirmed and convalescents, and also the suspects as they come in. Remember, a patient is still a patient, whether they come, they are confirmed EVD or COVID, depending on the disease, they're still a patient, and any medical care that is supposed to have been offered to them is supposed to continue. So the observation area is meant to make sure that the nurses or the clinicians are able to observe the clients and provide the adequate care. The medical office, that's also for the medical records done by the clinicians, so that they can be able to have up-to-date notes and also on the client progress. The space allocation, we have other areas, that is the creche, where the caregivers are able to visit, the vaccination site in case you are vaccinating, and other awareness activities. That means during discharge, so that you're able to advise the clients on what to watch out as they go to the community. And we also have the lab and the blood bank. Our blood bank, I know some people would ask, why do you have a blood bank? In this case, remember, a patient is still a patient, whether they have EVD and they are pale and they need transfusion, you need to provide for that. No care is denied to any client despite the disease that they've been diagnosed with. One, the flexibility and adaptability of the area. As we mentioned, the scalability of the ETU should be put in mind when allocating an ETU area, so that you can allow a change in the ratio of suspect to confirmed beds. And also, one of the things I'll mention is having a maximum bed capacity of 60. This is something that is coming in so that management of the clients can be easy and also seamless. Remember, as you get more patients, the clinicians also tend to be overwhelmed, and also mistakes are bound to happen. This is just a diagram, a sketch of how you can be able to help patients who are suspected and those ones who are confirmed before you await for results, and how you can be able to scale it depending on the results as they come in, and how you can be able to do that. So the red here is the ones who have been confirmed, and you can see as the cases increase, we also take over the other beds. And also the same for those ones who have been, who are still suspects. This is just a modular capacity of a 20-bed capacity room. But as I mentioned before, this is only scalable or modular depending on the site, space, and also with the number of clinicians on site. There's something that's also coming in, the spatial separation, that is the 2-meter distance that is supposed to be maintained at all levels. Remember, when you have clients, either children and adults, there's a reason why this space is maintained. Always make sure that it's appraised to them during admission as they come in for their treatment. And it should be wide enough to ensure that the separation reduces the risk and facilitates access and movement of the staff. And also remember, the staff, while they are doing the ward rounds in the ETUs, it's always a one-way. And also, you have to ensure that there are no sharps that have been left as you move forward. The sizes of the doors and corridors, they should be able to accommodate a stretcher or a bed that is going to go through in with minimal effort. So these are the things, basically, if you look at the recommended architecture of building a facility, if they are put in place, this is already adhered in place earlier. The flow is a one-way flow. It's clear and differentiated, both for the staff, the patients, and the materials. And as I've mentioned before, and it's been hammered for the last 1 week, the movement is always unidirectional and stepwise. If possible, and you have the resources, you should be able to mark all this on the floor. The flow of the patients, as you can see, we have the screening area. And then those ones who do not meet the case definition are able to be discharged and referred to a health facility. Those ones who meet the case definitions are admitted at the suspect area, and the ones who test negative are discharged, and then they are followed up for the next 21 days. For those ones who go to a confirmed area, they should be the suspects then who move there if they are confirmed. And then we have those ones who are discharged because they've healed. After healing, they go through a shower. We used to call it a happy shower for the clients as they go home. And then for those ones who, God forbid, die in the process of treatment in the ETU at the confirmed area, they are taken to the mortuary. All this should be seamless and should be labeled for the clinicians to be able to know that, and it should be, during their training, they should be able to remember all this. For the patients, still the same. And remember, if you look at this modular diagram, is that there is no area that the clients in the high-risk area are coming into contact with individuals within the low-risk area during this time. For the staff flow, we have an area where they enter through, and then they go to a changing room. The changing room, that's where they're able to put basic PPE, and also if they are putting on the advanced PPE at that particular level, it's done at that level. And then when they're within this level with basic PPE, they can be able to move in freely through the offices, maybe checking on the rota, any new developments on the patients that maybe if it's in the morning shift, what are the new developments that occur during the night shift, and in case of anything, what is needed before they go into the ETU. And then a reminder, as they don't, that's where they are putting in the advanced PPE. That means the mask and any other thing that is required before you enter into the highly transmissible area. And then for them to leave the high-risk area, they must remove the PPE. Remember, we always insist, doffing is a stepwise procedure and it's never hurried. And then when they finish their work, they can collect their personal clothing and leave the center. That's after changing from the basic PPE. This is just the modular flow as I've described and how it's done. And if you see it, there's the unidirectional kind of flow, which is evident all through, and there's no retracing of the steps from wherever they entered up to the place they exit. The materials that are needed here, remember that all the equipments, facilities, they should be able to be cleaned easily. Maintenance and repair should be easy, and then resistant to microbial growth. And that means you have to look at hard plastics, and if it's metal, it has to be stainless. And then they should not be porous. And the surfaces should be smooth and should not be having pits. And they, if possible, have transparent and soundproof material so that you can be able to monitor what's going on. We avoid walls in this kind of area so that in case you move out before you come in, you can be able to see what you're going to do before you don and go in. For the clinical aspects, all the rooms should be able to accommodate children and any patient with special needs, and even those ones who have undergone minor surgeries. Sorry to say that surgeons sometimes tend to fear all these things when it comes to this, but all patients, despite their condition or clinical status, need to be afforded highest medical care. If it requires major surgeries, this has to be done, and the surgeon has to put on appropriate PPE. And also, so we need to set aside at least one room for intensive care. In case of surgery, that means a theater, and also delivery. If we are to do a CS, it has to be done, and it should be equipped. We should not just say we have a room, an empty room with no equipment in that. Ensure the rooms are also visible and close to the nursing station just for observation. The psychological aspects and community acceptance. As we mentioned, remember when we have the double fencing at the border, we should be, the clients and the community should be able to have contact. There are those ones who will need their priest to be coming every day. Children might want to see their friends. Parents, adults might want to see their spouses. So let's make sure that this is maintained and they are able to maintain the relationship they have. For the community, they should also be having, we have an outdoor space for visitors for psychosocial support. And also when designing and constructing, involve the community. Don't be in a situation where you're going to put an ETU close to a cemetery. The community will not allow that, and will never be able to pick a patient from the community. And also invite people from the neighborhood and community leaders to visit the center before it opens so that they know what it is and what is going to take place in that area. And when you are doing the mortuary, involve the religious leaders like Muslims, and also Christians, and those individuals, different religions. They are those ones who wash the body. Also involve them in all this and tell them why some rituals might not be able to happen. Thank you so much for this. And in case there's any questions, I'll be able to take them at this level.
Thank you so much, Dr. Mariga, for that excellent presentation. It was concise and very to the point, and just giving us a sense of how these Ebola treatment units or centers should be established. So we can take a few questions. We are expecting a second presentation that's arising from a question that was asked last week around feeding of an infant born in the setting of an outbreak, whether the mother is infected or if the baby is infected. So we are expecting a second presentation. But in the meantime, we can maybe allow for questions and answers during this session. So I'd encourage all the people who've logged in to type the questions in the Q&A session. As of now, we don't have any questions yet, but if there are any questions, then we can take them at this point as we look out for the second presenter. So maybe perhaps I can ask the first question, which is basically reflecting on what you've presented. So is it possible that the COVID treatment units can be repurposed to meet the needs for Ebola treatment units? I know it may be a difficult question for you to answer, but what are your thoughts around this?
Okay. Thank you, Dr. Maritim. Yes, the COVID treatment isolation centers can be repurposed for this. And what is coming up is that globally, the isolation centers that we are creating should be able to be repurposed for any use as pertains to any infectious disease. It beats the purpose of how you are going to be creating different isolation units at one particular time, only that the basic principles during the construction of isolation units should be put in place. There are those infectious diseases that might be of low risk impact to the community, so you might need to scale them at that in that level, and also reinforce on some of the things that are needed within the ETUs. Some of the requirements for COVID and Ebola are nearly the same. The IPC measures are nearly the same. If you look at the patient flow, basically was also the same. The only thing that comes in is some of the requirements that either the clients need at that particular time. COVID required so much of oxygen, so we might with Ebola, which might not be the case. So repurposing has to be done. And I think, or going forward, counties and hospital management teams should be allowed to have an infectious committee that is able to look at this on how this is going to be done and how it's going to be adopted at that particular level. Thank you.
Thank you so much for that answer. And clearly, I think we are on track because we had a lot of isolation units that were based in the county. So it's a good thing to note that they can actually be repurposed. So I have a question that has been sent, I think, through the chat. So I'll read it out and you can be able to respond to this. So the question is, this facility looks like a high security zone and may have negative psychological connotation to the public, which may impede collaboration with the community. My question is, the issue of 3 fences with high wall, was it scientifically reached at, and is it standard regardless of the community outbreak? Sorry, regardless of the community the outbreak is reported to? Can we make it more patient and community friendly? So this is a question by Eric that has been posted through the chat. So maybe you can just share your thoughts around the question that he's raising in terms of the very high security and many fences, and therefore what would this mean to the community? Will it push away the community?
Okay, thank you so much. And also thank you, Eric, for such a wonderful question that you put forward. All this was evidence-based before it came into place. If you saw the 2014-2015 videos before, they had high walls and all that. The 3 fences, basically, we have 2 fences that are on the high-risk area, and the other fence is on the low-risk area. If you look at we say that the 2 fences basically are not, they're supposed to be transparent. So the individuals within the high risk and the ones who are on the outdoors are able to see each other and converse. And it has been evidence-based in this and community. If you realized in my, lastly, before I finished this, I said that the community should be able to access the ETU before opening. That means involve the community elders, involve the community religious leaders, and any other important person if it's politically, so that they're able to go through it and make changes and also make suggestions. So one of the things that you learn in public health is that if you do not have a community buy-in, your project is as good as dead from the start. Thank you.
So we are reassured that there was actually a scientific basis for the high fence. And I think what you clearly showed even from the diagram, you build this fence through material that people can look through. So it's not like a concrete fence, but it's actually a fence that's built through and has ability to allow people to see each other so that they can be able to even talk through the fence. So there are several questions that are coming, and it's good to hear some of these questions that seem actually to be coming from people in the county, which means that the target of this webinar is actually reaching the county teams. And one of the questions is really whether this information is available with MOH at county level for providers to use. And there's also a complement attached to that presentation, that it's a good presentation. So that is one, whether this information has actually been shared with the counties. to allow them, even as they design the Ebola treatment units, and particularly the high-risk counties that have been mapped and have been part of the preparedness process. Then there's another question from Leah, and this is around the staff who work in the isolation area. Where are they supposed to wash their uniform? So maybe you can speak to this, and then we'll continue from there. The first one is whether their information is available at county level, and then the uniform, where do they wash the uniform?
Okay, thank you for that also. I'll start with Hilary's question. It's also a good one, and I think this is a better forum for everyone to know that the Ministry of Health has been doing dissemination and trainings at the county level for the high-risk 20 counties that were identified through the Division of Disease Surveillance and Response. Training has been ongoing, and it's expected that those ones, the TOTs who are trained, can cascade that information to their colleagues at the facility. Yes, training has been ongoing and material has been provided. The next question about where the staffs are able to wash their linen. Within the low-risk area, there is a part for laundry. And remember, in this case, when you came in, when the staffs are coming in, they're able to change from their normal home clothes into mostly their scrubs in this level that they use at that particular level. So before they leave, they have to leave the scrubs within the changing area so that they be taken care of by the laundry team. So it's not, I know in our area where staffs wash their own materials, but in this kind of case, they are supposed to be put together and washed together. And I think the facilities are supposed to be able to budget for all that. Over.
Thank you very much. So there's another question around documentation, and this is around where will the people be keeping their files, for example, the clinical notes, and how does it happen in this setup, and how are they, for example, the patient files and clinical notes handled? So that is one. The second one is from Charles, and Charles is asking, how long does a center like this one take to set up, and what is the estimated cost? So that's around cost of establishing the center. And then there's an important question from John Tabu, and this is around the design of the Ebola treatment units. And his remarks really are around the fact that they seem to be designed to take a lot of human resource to sustain. So is that true? Or it may not be that. So he wants to know if truly they are human resource, they require a lot of human resource to sustain based on the current design that you shared. So maybe you can take those three questions around the keeping of the clinical notes and documentation. How does it happen in this case? And then the estimated cost to set it up, and how long it actually takes up to establish a center like that. And then whether it's true or not that it seems currently designed to require a lot of human resource to run an Ebola treatment unit. So you can give us a sense of how many people are likely to staff the unit and to care for the patient.
Okay. Thank you for that. I'll start with the documentation part. The documentation basically is done before you enter the high-risk area. At the observation area, that's where the documentation is done. For those ones who are able to be involved with the COVID management, remember you could go in, review your clients. You had to memorize whatever you are doing with all that, and then when you come out, that's when you would make your notes. So that one is taken care of at the observation area. That's where also these the nurses looking at the patients and all that and giving you the report. So that's taken care of at that particular time. In the high-risk area, you are not able to take notes. So your memory should serve you right. And in case you become overwhelmed, you can always ask for a timeout and come or dictate to someone who is outside to be able to take the notes on your behalf. Remember, we said it's a transparent fence that you can be able to see the individual on both sides and give them instructions on what to do. The cost of establishment, I don't know the exact cost in this case, as the materials are variable. In this case, most of the materials used should be within the available within the community. For an ETU in Nairobi, it would definitely be costly depending on how you are sourcing materials as compared to an ETU that you're building in Busia. You might end up using local materials that are within the area. What it means that you are not really creating anything out of the ordinary. What you are doing is barrier, the way nurses do barrier nursing. Basically, that's what you are doing. You are secluding places from other areas. So the material you use is basically what's available. If you have reeds, you use reeds. If you have tent material, you'll be able to use that. And then there's also the recommended the mesh kind of fence, plastic kind of fence, you can also use that. So basically, the architecture here is only supposed to move, direct you. The materials we did not, there's no dictation on what materials can be put in place. And then lastly, the human resource that is needed for this, it's not really extensive to set up. Why do I say that? Because mostly the stuff that you use have been repurposed from somewhere else for you to be able to use here. You are not bringing in any new person. You are not training any other new person. Definitely, the individuals who are going to be in this area have to have been trained in IPC, and you are going to use the available clinicians in place. The minimum number of patients in place depends on the number of patients you have. If you have one patient in place, you might maybe need 5 people, 5 individuals, just to quote arbitrarily. But no, it does not require a high human resource factor for you to be able to put it in place. As we know, even in facilities, we have the downtime where we have few individuals admitted, and the clinicians can be able to divide themselves according to that. So it's the same way that you're going to approach in this case. Thank you.
Thank you very much, Dr. Mariga. So we continue with the Q&As, and the questions are very, very interesting and informative, and just give us a sense that people are really paying attention to the entire presentation and the series. So there's a question from Dr. Lloyd Vincent, and he's asking, it's more like a remark, but inside there's a question. So is it aerosol spread in COVID from upper respiratory tract versus preventing contact in Ebola bring a difference in approach to handling the patients in question? So I think he's trying to ask, based on the mode of transmission of the two diseases, where COVID is largely a droplet infection, while Ebola is transmitted through close contact, bring a difference in approach to handling the patients in question. And I think the answer to that is yes. So maybe you can elaborate in terms of what would then this mean in the Ebola treatment units that you've already described. So that is one. There's a question from Charles, and he's asking, for the healthcare workers, is there a need to isolate at home, or are there any specific measures to take to prevent spread to their loved ones? You can touch on this, but I believe this could have been covered even in the IPC session that was covered on Friday. So maybe you can allude, you can just respond to this question by Charles in terms of the healthcare workers. How do they protect themselves from the loved ones after working in the ETU? There's a comment from Victor, and he's asking whether they can get notes from the training to the email for reference purpose and for passing the information. So I think this was announced earlier by Dr. Amina, that actually all these recordings of the webinars are available on the KNH webinar platform. So this is a resource that's available. You can actually watch the entire series by logging into the KNH webinar platform. And then there's a comment by David, and I think you may be able to cover this, but it may actually be covered in the presentation tomorrow. And this is, David is asking about an update on the current Ebola cases in Uganda at the moment and the risk level to Kenya. So maybe you can touch on the three comments, the contact versus droplet infection for the two diseases, and the handling of the patient, and then the healthcare worker vis-a-vis preventing infections to their loved ones. And then lastly, the risk level to Kenya by based on the current cases in Uganda. Where are we as of today? Thank you.
Okay, thank you. Thank you, Dr. Lloyd, on that. The question on aerosol spread in COVID versus contact in Ebola. Remember also Ebola is spread through body fluids. So what do we mean here by body fluids? They could be aerosolized, they could be sweat and all that. So they have some of the things depend, aerosol mostly because COVID and all that sneezing comes into place, but also any body fluids from Ebola, you can also get infected in this case. Yes, some of the measures, as I mentioned, when you are repurposing the isolation units might be different depending on the disease spread at that particular time. And that's why I've alluded that a hospital needs an infectious committee so that they can be able to look at this and also now do the right thing during repurposing of the isolation unit that they have in place. I hope I've been able to answer that, Dr. Lloyd. And for the healthcare workers, mostly during this time, they are secluded. They are not able to go home. What I know is that they are given quotas for them to be able to stay at that particular able, and then before they go home, they are tested. I think they used to have like a 1 week shift, and then before they go home, the 7 days they are tested, and then they are made aware that in case they are able to exhibit any symptoms while at home, they should be able to seek medical care urgently. And one of the things that is done also is an audit every day for patients, for clinicians who go into the high risk area on what they did as they were in there. And that is also maintained by a buddy system who is able to tell you what you did wrong. And in case your PPE got torn, that one is able to be taken care of early and measures put in place. The risk level for Kenya, basically Kenya is at high risk because we are in proximity to Uganda when we look at that. But now the infection currently to our country is on the lower side, considering that the government has put more measures into surveillance, and also we are on high alert for this. And I think the clinicians both at point of entries, that is both by road and air, have been trained on this, and also new tools in place and what they are supposed to be looking out for. And also the country, we're always monitoring the situation on a daily basis. There's a report that is produced for the ministry so that we can be able to either scale up our plans or be able to downsize it. And as you know, the Public Health Emergency Operations Center has also been activated so that we can be able to receive alerts. The alerts are being received on a daily basis and they are being investigated. Those ones that warrant testing, that one is also being done. So I would say that currently we are in safe hands. Any other, I think I can see, any other that I've skipped on that before we continue?
I think we have the second presenter already on the panelist, but I can ask you just to make a few comments because the questions, I think more are around comments and questions. So there's a question around digitizing the patient's data instead of using physical paper so that to minimize contamination and spread. And I think this has actually been part of the preparedness plan. So maybe you can make a comment on that. And then there's another question around, is decontamination set at doffing area? And if so, what is the setup like, including resources required? So maybe those two around digitization and then the decontamination at the doffing area and the setup around that and the resources required.
I'll answer the two. Yes, the digitization has gone into place. We've repurposed one of the tools that we use for COVID, the Jitenge. We've now have a case management and surveillance on that. Now given the name Jitenge Plus, so digitization has already been done and it's being applicable at the airport currently. And also receiving alerts. So that one has already been done 100% and it's already been used. Rollout has already been done. On the doffing area, any tools that are required, number one, I would suggest, this has always been the case. We have the IPC manager for the ETU who is supposed to be there when individuals are doffing. And any other tools that are supposed to be there, we have chlorine that is also supposed to be there. Water, soap, basically clean water, soap, and chlorine are supposed to be there because the process of doffing has all that in place. But always have an IPC manager during the doffing process. It helps a lot and it prevents infections because that's where mostly they occur during the doffing strategy. Thank you.
Excellent, Dr. Mariga, you've addressed all the questions that we had. So I just wanted to respond to a lot of the other comments that are still in the chat box, just to point you to where you get some of the answers. And some of the things are around community sensitization along the boundaries and villages, and the issue around the county and the preparedness issues, and also around the digitization. So tomorrow's session, we'll actually be talking about epidemiological surveillance and contact tracing. So we'll see what is planned and what has already been ongoing, and how many alerts we've responded to. On Thursday, we'll have a session on rapid response teams, and we'll talk about how these teams are constituted and what do they do. And then on Friday, we'll have a session on risk communication and community engagement. So under risk communication, we'll actually we'll hear more about the preparedness of people who are around the boundary villages and areas where the infection is likely to come from, what has already been done, what messaging is available for the community, and what has been done so far and what continues to be done as we still have a high risk level. So I urge all of you to please join the sessions that are for this week, so that you can be able to hear all that in the presentations that are planned. So thank you so much, Dr. Mariga. You're still on. Don't leave this, because a question might come up. But allow me now to invite the next presenter, Mr. James Njiru, who's going to talk to us around breastfeeding and Ebola virus disease and the pertinent issues that we need to be aware. So welcome very much, James, to make your presentation. So if you have a presentation, you can share your screen, and welcome.
Thank you. You can confirm if you can see my screen.
Yes, I can see it from my end.
And you can hear me clearly.
Very clearly.
Thank you so much. My name is James Njiru. I work for Save the Children Kenya as a nutrition specialist. I'm making this presentation on the request of the manager for nutrition in emergencies from the Division of Nutrition. So I want to make these notes based on what was also shared last time with the members, and I will be happy to respond to some of the questions, and I believe my colleagues are also present to respond to these questions. So this is a presentation on infant and young child feeding recommendations in context of Ebola. So I know we have had several presentations speaking into Ebola infection and IPC issues. So this slide just says that Ebola again is transmitted through body fluids, including breast milk. And a breastfeeding mother who is positive for Ebola increases the risk of transmission, and therefore breastfeeding should be discontinued and appropriate breast milk substitute should be provided. It is recommended that the best replacement feeding or breast milk substitute is ready-to-use infant formula or RUIF. And the volumes are based on child's weight and age as well. So what we are calling scenarios are actually recommendations. And so for an asymptomatic infant less than 6 months of age and a confirmed Ebola positive mother, so we should discontinue breastfeeding immediately, separate the mother and infant, give RUIF, and for Kenyan context, we said in the absence of this, because sometimes you might find that this is not readily available at the point of confirmation, then normal infant formula, what we are calling powdered infant formula, should be used. But hygiene issues are highly recommended, because we know in these settings, hygiene conditions can be compromised. So again, it is also recommended that we provide psychosocial support for the mother and the baby as well. So in scenario 2, where you have both the mother and infant both confirmed as Ebola positive, it's recommended that we discontinue breastfeeding, separate the two, and then give RUIF, and in the absence of that, if there was ordinary infant formula, then this must be guaranteed that that formula is acceptable, feasible, affordable, sustainable, and safe. Again, psychosocial support for the mother and the baby as well. So now scenario 3, where you have a negative mother, but a confirmed Ebola infected infant less than 6 months. Again, you separate the two and discontinue breastfeeding. Then support the mother to express breast milk. Again, here is a situation where the mother is negative, but the baby is confirmed positive. So we support the mother to be able to continue to express breast milk, and that breast milk is provided for the baby. So the previous presenters talked about the ETU isolation centers. It's recommended that this mother be supported to be close to the ETU, so that when the milk is expressed, that milk gets to the baby almost immediately. Remember, the shorter the time, the less exposure and risk to contaminate the breast milk. So it's highly provided, but of course there are logistics to go with that, and I think the panel have had previous questions regarding how the ETUs are set up, and now how this mother can be housed in the proximity of where the baby is being managed, and therefore I believe that is well taken care of. Again, psychosocial support for the mother is recommended. So again, now this scenario 4, where you have a symptomatic child who is now above 6 months, and a confirmed mother, confirmed for Ebola, or vice versa, where a confirmed infant, but the mother is asymptomatic. Okay, so either way, separate the two, offer complementary foods, including 2 to 3 cups of milk. Remember, earlier for less than 6, we were talking of RUIF, but here now, because the infant can be able to be fed on other complementary foods, it's recommended that that baby receives animal milk or cow milk, or follow-up formula, okay? And this must be UHT. It's recommended because that's it will not require any further processing or any further handling, so it's taken from the packet. So, and when I say from the packet, obviously it's put on a cup or in a cup, then cup feeding is recommended within the hygienic conditions. Then psychosocial support for the mother and the baby. After the recovery, and we are saying here, this recovery is confirmed through PCR, and I believe that has been taken care of. So Ebola still remains in body fluids, including breast milk, even if cleared from the blood. So infants less than 6 months of age whose mothers have recovered from Ebola are not able to resume breastfeeding should be fed on RUIF. There are several reasons why the mother may not be able to resume breastfeeding immediately, because the process of relactation requires practical support. In the meantime, RUIF should be provided for less than 6 months. For infants above 6 months, we've said UHT milk should be provided alongside other complementary foods. So it's recommended that the mother should not resume breastfeeding unless and until there has been 2 consecutive PCR tests separated by 24 hours that confirm that the mother is negative or both are negative. So do not resume breastfeeding for infants and young children whose mothers have recovered from Ebola unless the woman has 2 negative consecutive PCR tests 24 hours apart that confirm absence or clearly absence of Ebola virus from the milk. So for infants 6 to 23, again, now introduction of complementary foods, follow-up formula, if available, UHT milk can be provided. Then psychosocial support and follow-up at community level is highly encouraged. And then in Kenya, you know, we have the Breast Milk Substitutes Act, and recently we have regulations that have been published. So we are fully operating within the Breast Milk Substitutes Act compliance. So this need to be ensured routinely so that we don't have violations that are likely to arise in the response. So this slide, we have provided some provisions that need to be observed, even as we do replacement feeding. And I don't intend to read all of them. So these 2 documents are available to guide the response team. So we have this slide that speaks into how to support the nutrition care for the mother who has been either positive or suspected. So mothers should be taken for anthropometry measurement using the mid-upper arm circumference. Mothers should be taken weight and height. And therefore, when they are confirmed to be malnourished, that is the MUAC less than 21 centimeters or BMI less than 18 centimeters, they should be enrolled into supplementary feeding programs. And so when they are in that program, they are supported with the corn soy blend or super cereal plus. This is for their own nutritional support. So for infants less than 6 months, it's recommended that their weight, age is taken, and length or MUAC may be taken where possible. We have pilots that are ongoing for MUAC measurement for less than 6 months, but haven't been put into policy. That's why we are saying where possible. Length measurements can be a challenge, and especially where the workload is high and then you don't have adequate workforce. So we say in those settings, it's appropriate to take weight and age, and this can be used to establish the nutritional status for the infants. So those infants with less than -2 Z scores or MUAC less than 11.5 centimeters, then should be enrolled for treatment for acute malnutrition, what we are calling integrated management of acute malnutrition protocols. So we have protocols that prescribe how those infants are managed. For those who are less than 6 months, as well as those who are above 6 months to 59 months. So those protocols should be followed. This guideline will be provided for the response team so that it becomes a resource, a reference material. So for those who have severe malnutrition, that's less than -3 Z-score, weight for height measurement, or more less than 11.5 centimeters, without complications, they can be managed using our OTP or outpatient therapeutic programs. So sorry for that. We have put this slide to just to demonstrate, to help our response teams to cancel or even prepare the mother on how to prepare this ration. For example, if the mother is malnourished and has been put into supplementary feeding programs. And so this slide just speaks on how to prepare, but the packaging has this information. And so our teams, our response teams and frontline workers should be able to advise the mother accordingly using the front of the pack instructions on how to do that. So I beg to stop there, and probably we respond to any questions. And thank you so much. Back to you.
Thank you so much, James, for that excellent presentation. Nutrition is a very important component in managing patients who have EBD, and therefore taking us through how to feed the infant, what to do for a malnourished mother is really, really important and pertinent. And for clarifying, because this question actually came up when we first had the introductory presentation on overview, introduction and overview of EBD. So thank you for this very good slides and guidance. And we acknowledge the fact that they conform to the Breast Milk Substitute Act of 2021. So thank you very much. I don't know whether there are any questions following your presentation. Let me just check through the chat session, or maybe this is when people are typing their questions. Oh yeah, there's a question from someone anonymous, and they're asking about any evidence to support RTUIF versus PIF. So maybe you can answer that, but as of now, I don't see any other questions. So the evidence to support one versus the other.
Oh, yes. Thank you so much for that question. Yeah, there is overwhelming evidence from WHO, actually systematic review. So there is adequate evidence we can share. Again, from what has been put into that analysis, if I can just speak to a few, is that ready-to-use infant formula comes without requiring any preparation. So it's direct from the packaging. So one that minimizes any potential sources of contamination. And again, in an NITU, for instance, or even in isolation centers for that matter, that may not necessarily be in a very hospital setting that we know that IPC are at a very good level, then you can always see the risk that comes with the powdered formula, the mixing, even the source of safe water is also a point of a source of contamination. So RUIF comes ready formulated. You don't need to do anything. It's direct given to the baby. You only need to measure the volumes that need to be given, either 2 hourly or like 3 hourly, depending on the age of the child. Again, but I must say this, all infant formulas are not 100%. They are instance 100% like safe. There will be a percentage of risk, and there are microorganisms that have been found to be present, even where the manufacturing or even the industrial processes are very high. But that's the benefits out of RUIF outweigh the risk that might come with it. So that's what I can say. But again, now in our Kenyan context, this is not a product that we normally procure. We have developed a guidance on even how the government will go about this to procure RUIF, because it's purely for this use. Should there be no need, for example, because of preparedness, we need to preposition this commodity. Should it not be used in the Ebola context, then we are faced with how also to remove it from the market, like dispose. We have processes that we have provided. So I think I can say that for now, but I agree we will share the WHO recommendation guidance on this that has cited all the research evidence to support the comparison between the powdered formula or normal infant formula and RUIF. Thank you.
Thank you very much.
Hello, this is Anzala. May I ask a question?
Okay, go ahead, Professor Anzala. Go ahead.
Yes, in view of what we have just been told about mother and child and the whole aspect of transmission, could Mariga again go back and tell us, would the isolation facility be well prepared to take care of all these 3 or 4 scenarios where we actually have to separate? Are there nurseries? Are there all other things that we have now been educated? So Mariga, give us a sense. How will this work? How will these scenarios work in the event that really we get mothers and we have to separate? Over.
Dr. Mariga?
Let me call you back. Sorry, Prof.
Dr. Mariga?
Wazal. Hello. Can you hear me?
Prof,
Yes,
yeah, ask your question again, Professor Anzala.
Yeah, I hope you can hear me. What I was asking, in view of what we've just heard about the whole issues of Ebola and the clear issues of separation of the two for the duration, how well are we set up in terms of ensuring that we can actually separate mother and child and be able to take care of them in the duration, in view of what you are discussing about facility and the human resource? Over.
Okay, thank you, Prof. In view of the facility and the human resource capability at that particular time, remember we mentioned that the HR resources are basically scalable and they can also be contracted depending on the number of cases you have within that, and also the kind of care that is needed within the ETCs. So with the kind of what we've had with nutrition, all these are put in place. Remember, even a child is treated as a patient at that particular time. If they are put separately from the mother is counseled on why this is happening, and the children are put in a secluded place within the same ETU, but given the same facilities, and also the interaction between the HR, the healthcare workers and the children is more compared to what happens with the adults. In the adults, the visitation might be 2 or 3 times a day, but with children, it can be 2 hourly, depending on the kind of children that were admitted and the feeding times that are provided. Thank you. Taken care of, Prof?
Yeah, thank you. Yeah, so you can see those are the complications that we must be very aware of. They complicate the whole area. That's clear. Thank you.
Thank you so much, Prof. Andala, for the question, and Dr. Mariga for that response. I'm just trying to revert back to my screen. My screen has become minimized, so just give me a few minutes. I'm looking for it. Yeah, I'm back again. Sorry, my screen, I minimized it and I couldn't find a way of getting it back. So I don't know whether there are any other questions that may be outstanding. I think we've addressed many of the questions that had come to the earlier presenter, to Dr. Mariga. And there were not so many other questions from for the nutrition presentation, but thank you so much, James, for that excellent presentation. Like we said, some of the other topics that the questions have been directed to will be able to be answered between tomorrow and Friday when you cover the different aspects. So I'd like to urge all of you to attend. There have been several comments around CPD points that the KNH research team will be able to address. And then also the question, I think there's one person who has written a comment regarding being aware or having a link to register for the webinar ahead of time. So, yeah, most of the, many of us who have registered on this platform actually received the email 1 hour the day before and 1 hour before the commencement of the webinar. So please, when you're registering, please use a valid email address so that you can get the notification of the webinar 1 hour before. That's at 1 o'clock for the webinar that will start at 2 o'clock. So please include an email address because that will really help in terms of the communication. For people who've logged in from PPB, like you are told, the points, the CPD points, and I think for most of the other regulatory bodies, the CPD points come, and this is also communicated on email, they come 2 weeks after the event or a few days after. So just be vigilant, you'll receive your CPD points. I've seen an additional comment or question. Maybe you can take it up because we still have a few minutes to spare. So this is a question by George, and it is asking, is it advisable to wean off an infant at the moment the mother contracts Ebola? And I think this is targeted at James. And I think James alluded to this in the presentation. So I'll allow James to just respond to this, whether it's advisable to wean off an infant at the moment the mother contracts Ebola. So I think he gave a guidance of an infant who's under 6 months who's exclusively breastfeeding. And if the infant is already on complementary feed, so if they're aged 6 months to 23 months, but I'll allow him to answer this question. James, I hope you're still there.
Yes, I'm there. Thank you for the question. So, yes, it's recommended that when the mother is suspected or confirmed, separate the two. We have also said in the event that the mother is negative and the infant or the baby is confirmed, again, keep them separated, but support the mother to express breast milk, and that breast milk is provided to the baby. Of course, all the benefits of breastfeeding should be sustained through expressing and ensuring that the infant feeds on expressed breast milk. I think in line with that, I also want to re-emphasize that when the two are confirmed positive, initially there was an initial guidance that that continuing with breastfeeding outweighs the benefits, outweighs the risks. But further guidance, I think 2016 guidance is that there has been evidence on viral boosting. When the two are positive and they continue to, mother continues to breastfeed, there is a possibility of viral boosting, and that makes the disease more severe, the severity. So it's recommended that even when both are positive, they are separated and discontinue any breastfeeding. So I just wanted to add that, because initially there was a guidance that when both are positive, you continue breastfeeding. But recent guidance is that you separate the two until the breastfeeding should only resume when there are 2 consecutive PCR tests that confirm negative, and those 2 PCR must be separated by 24 hours. Yeah, thank you. Back to you, Marty.
Thank you for that response, very concise. I'm scanning through if there are any other questions. I think these are just comments around CPP portal and how to get the CPD points. This is a tongue twister. The CPD points for the webinar. And then a question around certificates for this webinar. I think we'll answer some of these questions tomorrow when we meet again. And then there's someone asking if there'll be a demonstration on doffing and donning. I think that's a suggestion. And then a question of CPD points. So there are many questions around the CPD points. Allow me to consult with the team on on the KNH webinar team, and then we'll be able to issue a very good response when we meet again tomorrow. So I think those are the main outstanding things, but I think there's been a lot of positive reception on this webinar, and we are really grateful for that useful feedback and the questions that you've all asked around the issues that we've discussed today, mainly around the establishment of the ETUs, the staffing, and even the other resources required to establish the ETUs or ETCs. And then the question that was outstanding around feeding of the infant and managing the mother-infant pair following an infection in either the infant or the mother. So I think we've already discussed this at length. So I think maybe I can allow the 2 presenters, Dr. Mariga first, and then James, just to give us some parting shots or general comments around the issues they want us to take home, like the take-home message for each of the presentations that they made. So Dr. Mariga and then James.
Dr. Maribeth?
Yes, parting shots, take-home message.
To the healthcare workers here, always be on the lookout. IPC should never be ignored at any one particular time. Whether you are handling a small flu or whether you are handling severely hemorrhagic illness. IPC should be a paramount and always seeing it always. Just one thing I would like to remind all the clinicians, take advantage of the trainings that are coming into the counties through your CHMT and the county director of health on this, that whoever goes for the training, at least the minimum they can do is disseminate the new knowledge that they always receive in this, so we can always remain updated. Thank you.
Thank you, Dr. Mariga. James, take home message, parting shot.
Thank you so much, Maribeth. I think mine is to applaud and really thumbs up for the team that is preparing all this work. I think we learned good lessons from COVID, and I see us getting well prepared for this eventuality. So mine is to congratulate the team, the organizers for this, plus our heroes who are on the front line in terms of the response. So I just want to say thank you. So for me, from the nutrition desk, I just encourage that even as we prepare for all this, nutrition assessment is very key. And of course, Dr. Mariga has said the IPC, that with that kept, I think all suspected mother-infant should be taken through nutrition assessment, because you can be having an infant who is suspected or confirmed, and yet having malnutrition. So that is very important. So that's my call to action. All clients that are coming through our ETU or isolation centers should be taken nutrition assessment alongside the other Ebola-related diagnosis. Thank you so much, and over to you.
Thank you so much, Dr. Mariga and James, for those very pertinent take-home messages. And we are grateful for the kind messages as part of the organizers of this webinar series. And we are grateful to the MOH training subcommittee, who have actually facilitated most of these sessions and continue to facilitate the session. So like I said at the beginning, we still have upcoming sessions tomorrow, Thursday and Friday. So tomorrow we'll have a presentation on epidemiological surveillance and contact tracing that will be presented by Dr. Samuel Kadibane. And then on Thursday, we'll have another session on rapid response team. And then on Friday, we'll have a session on risk communication and community engagement. So there's been a recurrent question and comment in the chat around sharing the link to other participants who would like to join and participate in this webinar series. And we want to encourage all of you. There are currently 629 or 635 people on the call. And we urge each one of you to bring 3 other people. So for this Ebola webinar series, we've actually expanded the KNH platform from previously 1,000 participants, and now it can host 3,000 participants. So we are urging and asking each one of you, 635 people on the call today, to bring 3 people each, so that you can be able to fill the platform. So kindly share the registration link to everyone that you know, and they can be able to join this webinar series, because the sessions that we have that are still remaining are very, very interesting. So please bring 3 to 5 other people so that they can all learn. So if you have been able to join the webinar, that means you already have the correct link, and you should be able to invite other people to join and participate. So we are encouraging all of you to bring other people. That's why actually we expanded this platform to be able to reach as many people as possible.
I posted the link on the chat.
Okay. Can the participants be able to see the chat? They can be able to see on the chat.
Yes, they'll be able to see on the chat.
Yeah, so for all those of you who are asking about the link, please click on the link and use that link to share with other people, so that you can bring 3 to 5 other people to join the webinar session. So that's a way of reaching out to other people, because that has been a frequently asked comment on the chat box. So you're all welcome. Without much ado, allow me now to close today's session, and we wish you a good afternoon. Thank you very much. Thank you to our facilitators and speakers today, and thank you for other people who've been able to ask questions for this very active interaction. We wish you all a very good afternoon. Thank you, and see you again tomorrow at 2 o'clock. Thank you. Bye.